We are joined today by our speakers, Drs. Cheryl Iglesias and Amy Park. At this time, I'd like to turn the microphone over to our first speaker, Dr. Iglesias.
Thank you, Robert, and thank you, OGS, for sponsoring this first webcast. It's a pleasure to be here tonight, and Molly, thank you for organizing it. I am a urogynecologist, and I direct the Female Pelvic Medicine and Reconstructive Surgery program at MedStar, and I am here in Washington, D.C., and I'm also on faculty at Georgetown. I'm a professor in OBGYN and urology at Georgetown University School of Medicine. I'm going to be moderating this webcast, so please feel free just to chat or put in your questions at any time. But the webcast is going to be, the whole lecture is going to be run by my colleague and friend, Dr. Amy Park. Amy Park did her undergraduate degree at Brown and then went on to medical school where she graduated with honors at the University of Rochester and went to a very prestigious residency program at McGee Women's Hospital associated with the University of Pittsburgh. After that, she also did her fellowship, which was a combined urogynecology and minimally invasive gynecologic surgery fellowship at the Cleveland Clinic, and has been with us at MedStar Georgetown since 2009. And she currently works in our division at the National Center for Advanced Pelvic Surgery and is an assistant professor in OBGYN and urology at Georgetown. In addition to her clinical duties, Dr. Park is a junior investigator with the Women's Health Initiative and has published in this area. And the Women's Health Initiative is the big hormone trial, but that is part of the National Heart, Lung, Blood Institute, or NHLBI, at National Institutes of Health. She's also been nominated and awarded a top doc status as well as a super doc status in both D.C. and Northern Virginia. So it is my pleasure to introduce Amy, and she's going to take it away.
Thanks, Cheryl, for that wonderful introduction. I'm so lucky to have Dr. Iglesias as my mentor, colleague, and friend. Well, today I'm going to be talking about breaking free from pelvic floor disorders, and this is sponsored by the American Urogynecologic Society. I just wanted to go to this pop quiz, and you don't have to, I know the participants can't really answer, but I just want to keep these questions in mind, and we'll go over them during the course of the talk. So as a woman, your chance of getting a pelvic floor disorders ranges 1 in 3, 1 in 4, or 1 in 5. Bladder control problems only occur in women after menopause, true or false. The number of adults with bowel incontinence is 5, 12, or 18 million. Risks for pelvic organ prolapse include age, childbirth, smoking, and chronic lung disease, lifestyle factors, or all of the above. So keep those in mind, and we'll circle back at the end of the talk for these questions. So today we're going to cover what pelvic floor disorders are, which include problems with bladder control, bowel control, pelvic organ prolapse, and how can I break free. And these include pelvic floor workouts and looking at the resources available on the Voices of Pelvic Floor Disorders and what the Pelvic Floor Disorder Alliance is. So 1 in 3 women will experience a pelvic floor disorder in her lifetime. And what is this mysterious pelvic floor? You can see a cross-sectional view here of the pelvic floor, and essentially it's a set of muscles, ligaments, and connective tissue in the lower part of the pelvis. I always say it's like kind of like a muscle diaper that covers the bones of the pelvis. And then what it does is it supports the internal organs like the bladder, uterus, rectum, and vagina. Let me bring up the pointer. And essentially,
Dr. Park, one of the participants asked if having a pelvic floor disorder, and what she probably means by that is some weakening of these connective tissue or muscles, leads to failure of any surgical repair.
It's a really good question. I think it's not going to lead well, first of all, people aren't going to have prolapse a repair unless they have a pelvic floor disorder to begin with. I think this is a question getting at risk factors for failure of prolapse repairs, and essentially we'll get into that later. But if you have a history of prior prolapse repair, if you have some underlying medical condition, and age, what stage prolapse, all of those factors play into whether or not your risk of prolapse recurrence is higher after surgery. The other thing to keep in mind is whether or not to augment the repair with mesh or not, and that can be a factor.
Okay, thanks.
Okay. So essentially, I'm taking this arrow. This is the bladder here. This is the uterus and cervix. Here's the vagina right here, and rectum is right here. Okay. Get rid of this arrow. So pelvic floor problems include problems with the bowel or bladder caused by weakened muscles of the pelvic floor, tears in the connective tissue, and the symptoms include pelvic pressure or vaginal bulge symptoms, leakage of urine, overactive bladder, which is that gotta-go sensation, difficulty emptying the bladder, problems with having a bowel movement, and leakage of gas or stool. Risk factors are age. Just basically it increases with age. What I always tell my patients is, people say, oh, I never had this problem before, but unfortunately, number one, when we age, our muscle turns to fat, and number two, our connective tissue gets less elastic. So that's why we all get a little touch of high blood pressure and farsightedness and wrinkles. It's all part of the same process where our connective tissue becomes less elastic. Childbirth injury, and it can occur in women who are younger, but it's a little less common. Lifestyle and behavioral factors, so obesity is a big risk factor. Smoking, which can also cause problems with your vasculature and coughing, and health conditions like stroke, if problems urinating and having a bowel movement like chronic constipation, and if you've suffered pelvic injury, like say I've had patients who've had car accidents and had a pelvic fracture or prior pelvic surgery. So there's bowel control problems, bladder control problems, and pelvic organ prolapse. I'm going to start talking about the bladder control. It's actually very, very common. About 18 million women in the U.S. have urinary incontinence. And you can see from this pie chart about 41% seek help within the first year, but about a third of women wait 1 to 5 years, and about a quarter of women wait over 5 years to seek help. I'm just going to go over some of the anatomy and physiology here. Basically, the bladder, I'll point it out again here, is this organ right here. And it stores the urine in the bladder, and it connects to a tube called the urethra, which is right here. And the muscles and nerves help control the bladder and urethra. When you go, it's a complex process where your brain says it's a socially acceptable place. So you're sitting on the toilet, you contract your bladder, and then the urethra relaxes as well as the muscles of the pelvic floor. And I like this little thing up here. It says, did you know the urethra and vagina are separate openings? I just had a patient last week who told me that she thought she was peeing through the vagina. So I think these are really, really good questions. And if you have a problem with controlling the bladder, it can be a result of the problems with muscles and nerves that can result in difficulty emptying the bladder, starting the flow of urine, leakage of urine, and having that urgency sensation, leaking urine with this involuntary loss, slower interrupted urine stream or sense of incomplete bladder emptying, and problems with sex. So we divide the types of urinary incontinence into stress incontinence, and this is the one where people leak with coughing, sneezing, laughing, lifting, exercising. It's basically with Valsalva. Urgent incontinence or overactive bladder symptoms include those feelings of urgency, like I got to go now. Sometimes people can leak with those kind of feelings, or go often, urinating like every hour, and then going throughout the night. Mixed incontinence is basically a combination of the two, and then continuous incontinence is just unpredictable, and it can just completely leak out at all times. So essentially, what we always say is we need to tailor therapy for what's best for you, in your lifestyle, your underlying risk factors, potential complications, and follow-up care issues. Diet and exercise, always important. To lose weight if you're overweight, to limit alcohol and exercise, do pelvic floor exercises like Kegels in order to keep the pelvic muscles healthy. And then the bladder diary can help you track how often you're going and help you develop some healthy bladder habits. It's kind of like my Fitness Pal, I don't know if anybody has that app, but it essentially helps with tracking your exercise and calorie count and things like that. So that's also an option. It's called Bladder Tracker.
We have a question, Dr. Park, about the Kegels. How many Kegels should we do daily, on a daily basis?
I want to make a joke here about it's not it's about the motion of the ocean, because it's like, the typical answer is you're supposed to do 3 sets of 10, and you want to do 3 sets of 10 of the short Kegels, where it's like you squeeze and let go, and then the more prolonged Kegels where you try and hold it for 5 seconds and let go. But what I often find is that when I have people bear down or try to do a Kegel in the office, they're actually bearing down. And so it's really important to do them properly. That's why I refer many, many patients to pelvic floor physical therapy. The pelvic floor physical therapists are all women who either use biofeedback or their fingers to make sure that patients are engaging the correct muscles when they're doing Kegel exercises. And do them correctly. It's just like when you go to the gym, you want to do the exercise with the correct form. If you do it with poor form, you can end up being counterproductive and causing more damage. So I think, form and function obviously are important.
All right.
Any other questions?
I think we're good for now, but we have some questions about treatments.
Okay. So treatments, stress incontinence, these are pictures of pessaries. They're not ancient torture devices, but I want to point out that all of them have this little knob at the end. So essentially, I'll put a little pointer here. So see how these have little knobs, and they're placed in the vagina. I always call them pessary spanks for the vagina. When they're in, they push back the prolapse or help with the incontinence. An inert silastic, it's not rubber, it's actually silicone vaginal insert, and they're different shapes and sizes, and basically we size them to fit each patient. I tell patients it's like a pair of shoes. You take it around the office. It's like going around in the store with the shoes. Sometimes it doesn't fit properly, so we have to come back in a couple weeks just to make sure it fits okay. And it supports the bladder, urethra, and kind of compresses it so that people don't leak. Physical therapy, I talked about the Kegels. Biofeedback is basically either using the fingers in the vagina or a little sensor to make sure that you're generating enough muscle strength. Pelvic floor muscle nerve stimulation and exercises. So on to other treatment options. Bulking therapy, it's like urethral bulking therapy is an outpatient procedure. We do it in the office. It's where we inject a little bit of gel-like material around the urethra at the bladder neck, and it helps block the leakage. The analogy I always draw with my patients is kind of like the wrinkle bulking stuff that puffs up the wrinkle so that it's not as big of a furrow. It's the same thing, but at the bladder neck. So it coapts the lining of the urethra and keeps it closed instead of open. It's a lower success rate than surgery, but the whole goal is to improve quality of life. And I recommend this for people who don't want to have surgery. They can't do surgery for whatever reason. Like I have a patient who takes care of her husband who has an underlying neurologic condition, and she just can't take the time off to do surgery, or other patients who are too sick to undergo surgery, or, there's a variety of reasons. People who want to get pregnant. Surgery helps to support the urethra and bladder. It aims to stop and reduce urinary leakage, and the whole goal is to improve quality of life. Just to go back to this, I do want to touch on the main surgery that we do for this. It's a sling. It is made of the mesh, which is causing a lot of hysteria, but it's still considered the gold standard surgery for stress incontinence. The
great thing is, Dr. Park, we do have a patient who can talk about her personal experience on that one, too.
Okay, do you want to have her talk right now?
No, I think we'll finish up with the urge, and then we can do the patients. That'll be great.
Okay, so incontinence, or that gotta-go feeling, treatment options include lifestyle changes, so retraining the bladder, learning ways to control when you go, exercises like the Kegels, dietary changes. I have some patients who drink only caffeine. That's not good because caffeine is a diuretic and it's a bladder irritant. Carbonated sodas, things like that, all bad for the urge incontinence. Physical therapy, like I talked about, the pelvic floor muscle training. Medicine, so bladder relaxant medicines. The most common ones people encounter, like Detrol, Ditropan, Vesicare, Sanctura, Enablex, and surgeries. The surgeries that we do really frequently, it's actually not really even a surgery, it's an office procedure. It's Botox. People are always joking, can you inject Botox into my wrinkles after you're done with my bladder? But in any case, it's where we dilute a little bit of Botox and then inject it all over the back of the bladder, and it's 70 to 80% effective. It lasts for 6 to 9 months. You're more likely to be dry with the Botox as compared to the medication. The bladder nerve stimulator, it's neuromodulation. The brand name is called InterStim, and this is a picture of it to the right here. Essentially, it's like a little pacemaker for the bladder. And then tibial nerve stimulation, we call it PTNS, is percutaneous or posterior tibial nerve stimulation. And it works in a similar way. The bladder nerve stimulator and the tibial nerve stimulation basically sends signals to your brain so that your bladder will work better.
So, Dr. Park, we have a question about the medications. Are there any medications that won't cause drying? The side effect that half the women end up stopping the medication, not because it wasn't effective, but because the side effects.
Yeah, that's a really good question. A lot of the discontinuation rate for anticholinergic, which is the main class of medication to treat overactive bladder, they include the dry eyes, dry mouth, and constipation. The way to get around it is to use a transdermal formulation, so something that's put on the skin, either the Oxytrol patch, which is over the counter, Gelneek, which is still prescription. It basically avoids first-pass metabolism so that the liver doesn't create these metabolites that cause those drying side effects. The other option is a drug that just came onto the market in the past 1 to 2 years. It's called Myrbetriq, or mirabegron, and it works in a completely different way than the anticholinergics, and that tends to have less drying side effects.
Thanks.
All right, so you want to talk about the patient stories, Cheryl?
Yeah, I think this would be a great time to do that, and I'd like to invite Becky to talk about her story first. Becky, are you on the line?
Yes, I'm here. Thank you.
You're welcome.
So basically my symptoms were that sense of urgency and leakage of urine and needing to go often and not very much would come out and having that sense of not emptying my bladder, which in fact I wasn't. So I finally managed to find you, Dr. Iglesia, and you changed my life by giving me the Botox treatment. Some of the things that I encountered before I had Botox treatments to my bladder were I'm a runner, and if I wanted to go out for more than 3 or 4 miles, I would have to find a little place to go to the bathroom because I couldn't go that long without having to urinate. I definitely had trouble, shopping and traveling on planes and such, like if they put the seatbelt sign on and I had to go to the restroom. I've definitely been approached by air marshals while having to sort of take care of business.
Oh, God.
And on top of that, I definitely encountered bedwetting. So as a result of getting Botox every 6 months or so, I'm able to have bladder control. I don't get up 3 or 4 times in the middle of the night to go to the bathroom. I sleep better, and I just don't think about going to the bathroom anymore.
And you had tried some medications too, right?
I was on Ditropan, and Ditropan definitely did not work well for me. And I agree with everybody who says the dryness. I had the driest mouth. It was difficult to speak. I felt like I always had to have a bottle of water with me, which then, of course, contributed to needing to urinate. I mean, it was definitely not, a very good situation.
Thank you for sharing your story. I think there's a lot of people who have a lot of angst when in those social situations where you're not sure you can make it to a bathroom in time. It can be devastating to have an accident and really affect your intimate, the way you feel about your body.
Yes, and every time I would go somewhere new, having to figure out where the bathroom was, knowing that at some point I would need to go urgently. I can't tell you the number of times I've had accidents where you're dressed up and you've got urine sort of running down your leg and you're pretending like it's not happening. So it's just a complete relief not having to worry about that anymore.
You were able to get off most of the meds, right? Or
I'm not on any meds at all. I just do the Botox treatments, which I like that you pointed out, isn't surgery, that it's just, about a 30-minute in-office visit, and it's in and out, and you're back at work, and it's not disruptive to your life in any way, shape, or form, other than keeping you from having accidents.
Oh, thanks so much. What about Erica? Erica, are you on the line? Because she has a different story.
Yes, I'm here. So I found I was sent to Dr. Iglesia about a year after having a hysterectomy. I was definitely one of the ones who waited about a year to let my physician know that I was having some issues. One of them being urinary incontinence, particularly when I was working out at the gym or when I had a full bladder and I would laugh or sneeze and cough. I guess the situation was also complicated by vaginal prolapse after my hysterectomy. I decided, I opted for surgery. I guess I wanted something, that might have a, permanent fix, and I guess I say permanent loosely, but a longer time frame for a solution. So that was my reason for opting for the surgical approach.
And how did that turn out?
It's great. I can work out at the gym, and I'm not, kind of like Becky said, I'm not pretending like not leaking while I'm running on a treadmill or when I'm at work or out laughing. I'm not worried about those things and pretending like it's not happening. So I am satisfied.
And this might be a good time then, Amy, to talk about that sling thing that you were saying about the mesh, since that's one of the things that Erica had.
Yeah, I was just going to say that my patients, thank you so much, Erica and Becky, for sharing your experiences. And, I think the sling especially has been getting a bad rap. And there's all these advertisements on TV from these, personal injury law firms. And essentially what I tell my patients is that there's been a lot of randomized surgical trials comparing the mesh sling to the traditional incontinence repairs, and all parameters are better for the mesh sling. That's comparable or better cure rates over the long term. We have good 7 to 10 year data. There's less operating room time, less blood loss, less pain, early return to regular activities, and they just perform better on all counts. So I think there's a lot of misinformation out there on that count. So I always do a little bit of education about it because a lot of people have questions about it. And it sounds like you had that procedure, Erica, and you're pretty happy, right?
Definitely. I'm really happy.
And I just want to echo that your experience is just really common. We do these procedures, and they're very well tolerated, very minimal in terms of pain or and recovery time, and it gives people the control over their lives again. A lot of people do bladder coping strategies like bathroom mapping, fluid restricting. People know that they're going to go out for the day. They don't want to drink anything. They go to the mall. They know where all the bathrooms are. They don't want to go to a new place. They limit their activities because they don't want to, exercise. They want to sit down all the time. All these kind of things. I mean, do you not want to laugh? That's people want to be able to live the lives they want to live. So I think, the good news is there are treatment options to help people regain their control over their lives.
Yeah, let's move on to prolapse.
Okay.
Big pelvic floor disorder.
All right. And then I did see there's a question about the new medication that just came out. It's called mirabegron or Myrbetriq. So pelvic organ prolapse, about half of women between the ages of 50 and 80 have some sort of prolapse. These risk factors increase with age. I mentioned that earlier. So especially postmenopausal women, there's about 11% lifetime risk of prolapse surgery by age 80. And the risk factors include childbirth. I always say each child is like a bowling ball coming through the vagina. Lifestyle, so obesity, tobacco use, and other underlying health conditions like chronic lung disease. So pelvic organ prolapse, or POP, where the pelvic floor muscles and ligaments are stretched out and become too weak to hold the organs in the correct position in the pelvis. And then symptoms include this vaginal bulge sensation where the vagina, the tissue is coming out of the vagina. The most common is where the bladder is coming out. It's called a cystocele. There's dropping of the rectum or rectocele, and then dropping of the uterus or uterine prolapse. And just to go over the anatomy again, let me grab the pointer. So the bladder is over here and it's pushing down. The rectum is this part and is pushing down like this, and then the uterus is this part and it's coming down. So symptoms include pelvic pressure, heaviness, vaginal bulge. I've had some really funny descriptions of it. I grew a penis. I have a chicken nugget coming out of the vagina. Things like that. But
pocketbook.
Yeah, exactly.
Junk falling out of the trunk.
Yeah, the junk's falling out of the trunk. Urinary problems, so difficulty starting to urinate, and then a weak stream. Bowel problems, and it's basically from the stool getting trapped because it's not the right angle. So sometimes people can have chronic straining or pushing to have bowel movements. And then painful sex or pelvic pain. And then sometimes people can have low back pain associated with a bulge. It's called referred pain. It's where the ligaments stretch out and it activates the nerves that supply that area, and then people can get some lower abdominal and lower back pain. So essentially, prolapse is not a life-threatening condition, but it's an annoying quality of life condition. So these treatments can help people maintain, improve and maintain their quality of life and their sexual health. So one option is expected management. It's a conservative approach, just watchful waiting, making dietary changes, doing those pelvic floor exercises. The pessary, I mentioned that earlier as a treatment for stress incontinence. It supports the bladder, uterus, and vagina. Like I said, it's a Spanx for the vagina. It pushes back the bulge. And essentially, surgery is should be tailored to every woman's situation, because surgery is not for everybody, and certain surgeries are better for certain individuals and not for others. And it basically needs to be tailored to your body, your anatomy, your underlying health, your history of prior surgeries, your desire to retain sexual function, because some of the procedures leave you with a shortened vagina, actually one of the main procedures, and then the surgeon's experience and training. And one of the nice things is now with all the minimally invasive procedures out there, there's so many options. The goal is to restore normal anatomy, improve quality of life, most importantly, and reduce a bulge. And, I would say just try and think about yourself and what works best for you, and not judge on whether or not somebody else had a success or failure. And just discuss it with your doctor.
Well, let's go back to that about the surgery. If you could go back one slide, because we have about 7 questions here. And I knew that we would get a lot of questions about this, Amy, because it is such a common problem when 1 out of 3 women has it. So can you talk about treatment for rectoceles, which is the bulging of the rectum into the vagina, and any new treatments for bladder surgery, bladder prolapse?
Okay, so let me just start with the rectocele. Basically, the rectocele is where the rectum is sort of pooching out into the vagina, the posterior wall of the vagina. The most common procedure that we do is a rectocele repair or posterior repair, and it's a procedure where we use sutures to plicate the vagina and push it back into its normal position, and that can be augmented by mesh if there are underlying other conditions like recurrent prolapse, inability to have, abdominal surgery, etc.
But Amy, isn't it true that most of the rectocele repairs do just fine with the native tissue?
Yes, absolutely. And it would be a very unusual circumstance to need to augment it with the anterior or the posterior mesh. The other option is using a pessary.
And the special pessary is just for rectoceles, something called a gay rung is one of them.
Which one?
The gay rung.
Oh, the
rainbow-shaped ones.
Yeah. And then the surgery for new surgery for bladder prolapse, I do want to back up for 1 second. Bladder prolapse, we know that cystocele is about 50% of the support for the anterior wall. It comes from the apex, or the top of the vagina. So one of the tenets that your gynecologists really believe in is that you have to support the top of the vagina in order to get a good repair of the cystocele, okay? So, one of the repairs that you can do for bladder prolapse is an anterior repair, and usually we would tack up the top of the vagina to the either do a native tissue repair and tack it up to your own ligaments, so either sacrospinous ligament fixation or uterosacral ligament suspension. The other one that we most commonly do is called a sacrocolpopexy. It's putting a mesh on the anterior vagina, posterior vagina, and tucking it up to the sacrum, and that we do laparoscopically, either with or without the robot.
So actually, I don't know if Erica's still on the line and wants to just talk about it, because that's something she has some experience in. And now that, oh yeah, do you want to just talk about, why we had to do that at the combination of your sling surgery, also do using the mesh through the belly button incisions?
Sure. Like I said, previously I had hysterectomy, so as a result of the hysterectomy, I had a prolapsed vagina as well as a prolapsed bladder, and I was having pain, severe pain, during sexual intercourse, and that was definitely something that I didn't want to live with the rest of my life, and I had plans plans to remain very active. So again, that part of my life is very important to me. So I just wanted to try something to get it taken care of. In both issues, the urinary incontinence as well as the pain during sexual intercourse, it actually greatly affected my confidence, as well as, I guess, the feeling that I had as a woman. So yeah, those are some of the major reasons. I decided to go ahead with the surgery.
The pessary, it only pushes back the prolapse when it's in, and then when you take the pessary out in order to have sex, I mean, it doesn't take away that feeling. And the most common things that I hear from patients in terms of pain with sex is it feels like it's hitting something. I just talked to several patients today about that self-conscious feeling, and, you know, it's like, so we have to feel bad about our muffin top and our wrinkles and our hair, and, you know, and then the vagina, you know, hanging out is another thing that it cuts into the confidence. So I've had so many patients after surgery tell me, oh, Dr. Park, I feel so much better. This makes me feel like normal again, and, you know, nobody likes the rubbing of the vagina and their underwear and feeling self-conscious about it in terms of partner. So I think your experience echoes what I hear all the time, and I'm glad you had a good experience.
You know, this is an interesting question, and maybe Erica and Dr. Park can answer it, but the question was about postoperative management after a sacral colpopexy. So again, that's where you take like a Y-shaped mesh and you kind of like attach it to the top of the vagina, between the bladder and the vagina, and between the rectum and vagina, and bring that up to the sacrum. So this Wendy asked whether or not bending causes any problems. I assume that she means bending at the waist, or it could be bending at the knees. And then the other question was, why are so many women not given literature on limitations after this type of surgery? So I think it'd be great to hear from both.
Will cause any problems with the sacral colpopexy. I mean, obviously Erica went through it. Did you feel like you had any problems?
I don't feel like I have any problems with bending or.
Well, what about the limitations? Because I don't even know exactly what we told you. I have to say, there's not a lot of evidence on what the limitations are, because quite frankly, just getting up of a chair probably has more pressure than vacuuming and you know, picking up a jug of milk and coffee.
Yeah, actually, this is a really good question. I think this is a realm of like mystical thinking. We all do it and give patients some guidelines on physical activity limitations after surgery. I mean, the definite one is no intercourse, but probably Cheryl and I just went to our annual meeting. It was like the International and National Society meeting in July at the convention.
By OGS.
Yeah, at OGS. And basically there was a really interesting video where these brilliant people put in sensors to measure how much force is generated when you do these daily activities like vacuuming and lifting weights and lifting a bag of groceries, et cetera, et cetera. And it probably doesn't really matter that much, but we're all paranoid that it's going to generate a lot of force. So we give those instructions, but really I don't think there's a lot of data to support it, but we all do it anyway. So
I have to say, just anecdotally, the biggest thing is avoiding constipation, particularly in the immediate postoperative period. See, the thing is, when you're doing those things, the amount of pressure to the pelvic floor and your vagina is very brief. It could just be a quick second with a cough. But if you are straining with constipation and really bearing down, then that's sustained pressure over many, many seconds. Erica, how soon was it before you actually resumed, you know, doing your regular steps, driving, walking, and then even going on the treadmill and going out to the gym? Because I don't actually know the answer to this question.
I was a little spoiled, but I guess the restriction that you gave me, I believe, was 4 to 6 weeks as far as lifting anything over 15 pounds. as well as
well, I'll just disclose there's not a lot of evidence. That's just what we tell you, the standard party line.
Right. I think after my first visit, I again wanted to get back to doing some type of exercising, and I guess just as a precaution, I wasn't. I still had the weight restriction as well as no triangular positions because I had asked about yoga. As far as the spoil part, I was a little pampered between my family and my fiance. They just didn't let me do a whole lot. And even still now, I'm still a little sheltered or protected from doing a whole bunch. But honestly, when I sneak into it, I feel fine.
Yeah, and then generally after 3 months, you're pretty much,
Yeah, so most of the healing has been done, and there's pretty good evidence on that. But yeah,
somebody else had a question, Amy, about levator avulsion and how it affects prolapse.
Oh, that's a really interesting question. There's been a lot of MRI studies, so the magnetic resonance imaging on, and that's out of the University of Michigan, and they've correlated these tears in the muscle with certain defects that happen. So like I said, a childbirth injury is essentially a bowling ball coming through the pelvis. On average, it's 6 to 9 pounds or 10 pounds, and usually the vagina is very small, and it has to stretch and accommodate the baby's head coming through, which is the widest part of the baby. And then for a long time, there was a debate on whether it was muscle injury or if it was nerve injury, and it's now the thinking has shifted more towards the muscle injury, which is a levator avulsion. So what she's referring to is the levator muscles is part of that pelvic floor. It's the muscles that cover the pelvis, and they can be damaged during childbirth. And when you have these tears in the muscle, it can lead to the prolapse. And if I remember correctly, the levator avulsions usually are more common on the right, and that's just because of the way that the baby usually navigates the birth canal. There's a sigmoid colon on the left, and then the baby's head has to turn in order to navigate the normal anatomy. So that's what can happen.
And, some of the most severe cases of prolapse that I've seen in my 15 years of practice are women who have these avulsions, and it's not just the bladder or the uterus or the vagina coming out. It's your whole pelvic floor, and it's often accompanied by rectal prolapse. So it's very different from a rectocele, but the rectum is actually telescoping outside of the anus. So the whole pelvic floor, which is, all your muscles and your soft tissue, have been globally damaged, that every time you bear down and strain, it's like coming at you. So we have to not only do the lifting of the bladder and the top of the vagina and push back the rectum bulging, but we actually generally have to lift and do what's called a rectopexy and pull up the rectum as well. So it's
Absolutely. That's a really good point. Like, you can get a perineal seal, which is that area between the vagina and rectum that can just balloon out and bulge out. It's really important to go to a physician who is experiencing pelvic floor problems, because if you have rectal prolapse, it's really in your best interest to have everything repaired at the same time. I've had several patients who've had their vaginal prolapse repaired and then their rectum comes out because, the pressure goes to the area, the weakest area. So then they have the rectal prolapse repaired and then their vagina comes out again. So it's like, unless you address those at the same time, you're always going to have some sort of defect, and then one or other part is going to be coming out.
Before we're moving on to the bowel problems, another question on do you encourage women to avoid high-impact activities after surgery? And I'll just answer that I actually do. I think you can do on the treadmill, do the elliptical, walk upstairs, anything where both feet are touching on the ground, but if you can do other cardiac activity that's not like jumping, and the triangular poses or doing dead weights, with your legs separated and stuff. I'm kind of not into that after surgery.
Yeah, I agree. I'm with her there. The funny thing is, or not the funny, the great thing is, our patients feel so great after surgery. They're like raring to go. Don't you think, Sherelle? always. My patients, we see them at 2 weeks. Afterwards, like, so what kind of exercise can I do? I'm like, don't push yourself too hard now, but I can understand you want to stay fit and, maintain your routine.
Then I want you to do a little bit about the bowel, but then answer another question that was here earlier. I actually deleted it by accident, which was, what about this specialty of urogynecology, female pelvic medicine, and reconstructive surgery, and why is it that not all urologists or gynecologists are the same, in the approach to this? Okay.
Well, that's a really good question. I think there's, in general, in the general public, there's just a lack of awareness of pelvic floor disorders and treatment options, and that there are specialists that can address these problems. I think some urologists, I think there's maybe a little bit of a lack of awareness of female issues, because I think their training does focus more on males, prostate issues and kidney stones and things like that. Luckily here, we actually train the urology residents, so they definitely have more awareness of these issues. I think also our field of pelvic medicine, female pelvic medicine and reconstructive surgery, was just certified as a subspecialty 2 years ago. I think there's been many, many reasons for that, and traditionally people have been sort of jealous of their turf, I guess is a nice way of saying it, because there's so much overlap between urogynecologists and urologists. But now I think people have come to the conclusion that there's enough for everybody, and there's specialized training for these conditions, and that we're really doing a service to women with these issues to have a subspecialty addressing these particular issues.
Yeah, that's another late-breaking question. How do you make more women aware of the possibilities of prolapse and break the stigma?
Well, this webinar is one. I think do you remember when Rock Hudson came out with AIDS? Like, we need somebody to come out with her urinary incontinence and her, stress incontinence story, Angelina Jolie or something. Unfortunately, it's like a celebrity culture. But I think also as people age, I actually think there's just a lack of awareness about women's issues in general. I can't tell you how many patients I've had who are going through menopause even, and people are like, everybody goes through menopause. How come nobody talks about this, And it's like all the women's issues are in the closet, like menopause and pelvic floor disorders and other things like that. So that's part of it too,
I'm curious as to Becky and Erica, if you had ideas of, how you learned about finding help from a urogynecologist or a specialist who treats prolapse and incontinence.
Go ahead.
I'm sorry, Becky. I actually was referred by my gynecologist who's been treating me since I was 16. He referred me to him. Great doctor, great physician, and he thought Dr. Iglesia was the best person to address the issues that I was having.
Thank you. How about you, Becky? What ideas do you have?
It's definitely something that I've scratched my head about, because I had been seeing a urologist for several years as a result of my spinal cord injury that resulted in the lack of bladder control, and he said that I was experiencing a pretty good quality of life, which I didn't really agree with, and I just happened upon your colleague, Dr. Iglesia, at the, park when we were all playing with our kids and got to talking. So I sort of stumbled upon it, and I've been spreading the word. Anytime I hear a woman say she has any trouble, I'm the first to say you should see a gynecological urologist rather than just a straight urologist.
So you want to do a few minutes on, thank you so much, Becky, and thank you, Erica, about fecal, Amy?
Sure. Okay, so bowel control issues. About 18 million adults have fecal incontinence. It's also known as accidental bowel leakage. It's about 1 in 12. And essentially this caused a lot of stigma, people who were very embarrassed about it, and we just want to encourage people to discuss it with a doctor. And there's often underlying medical conditions like IBS or chronic diarrhea disorders, and there are treatment options available. And this is just a picture of the bowel. And just to review the anatomy and physiology, muscles and nerves in the rectum and anus hold the stool and let you know when the rectum is full. So the rectum is basically a holding area for stool. It's like the last stop before the stool comes out. So this is the rectum right here, and it's just, this lining right here. External anal sphincter, internal anal sphincter, and the anus. This is just the whole complex that the sphincter is a muscle that holds things in. So sometimes there can be damage to the anal sphincter from childbirth. Pelvic floor and sphincter muscles work together to help with bowel and gas control. And the control problems include accidental loss of gas or the stool contents. Chronic constipation affects over 4 million people in the U.S. Constipation can consist of symptoms like having a BM less than 3 times a week, having hard, dry, small stools that are difficult to get out, straining, abdominal bloating, pain with bowel movements, and then diarrhea. So this is loose, watery stools, passing loose stools 3 or more times a day, and if you have more than 2 days, it may signal a problem. Problems like inflammatory bowel disease or some, lactose intolerance or, there's a variety of things can cause these issues. So dietary changes. So we always talk to people about doing consuming a high fiber diet. It basically bulks up the stool and helps passage of the bowel movements that go through or stool that go through the rectum. And that high fiber diet consists of more whole grains, fruits and veggies, high fiber cereals, and fiber supplementation with things like Metamucil, psyllium, it's basically psyllium, or Benefiber, things like that. Essentially, other dietary changes for fecal incontinence, avoiding spicy foods and caffeine, those affect the sphincter control. And then constipation, avoid using eating starchy foods like rice, pasta, or white bread, just trying to increase more of the fruits and veggies. So options for constipation include the stool softeners. For loose stool, you can take anti-diarrheal medications. I often recommend Imodium. Physical therapy, it basically trains the pelvic floor muscles to hold more or tones them up. It's kind of like weight training. And it may include biofeedback, and then you can go to a pelvic floor physical therapist, and we can refer you to those specialists. Surgery is also an option. The whole goal is to improve bowel function, like emptying, control, and help with bowel emptying at the appropriate times. The types of surgery include bulking agents. It's called Celesta. It basically puts a little bit of hyaluronic acid in underneath the rectal mucosa, and it's an office procedure. It's not very painful because it's above the dentate line. A pacemaker for the pelvic floor bowels. It's the same that we talked about for the overactive bladder or urgent incontinence. It's the interstim. The anal sphincteroplasty or sphincter repair, basically if the muscles have been damaged during childbirth, we can reconstruct that area so that the muscles are together again, and an anal sling. So there are support networks available. You can work with your doctor to find the best treatments for you. And it's basically, pelvic floor disorders are not considered a normal part of aging. They can be treated successfully with the help of a specialist. People can be taught how to Kegel, and you can go to voicesforpfd.org in order to find a fact sheet on Kegels. And just be open with your doctor about your symptoms and, asking about treatment options. Ask about seeing a specialist. Luckily, it sounds like Erica was referred by her physician who had some awareness about these kind of issues. Becky was lucky to run into, somebody who knew about Dr. Iglesia. But if you need other resources, this voicesforpfd.org is a good resource, and to find a doctor that's comfortable for you. The PFD Alliance is a partnership of advocacy, professional medical organizations, physicians, health providers, nurse practitioners, and scientific discovery corporations. You can see here Allergan, Oggs, Astellas, Boston Scientific, Medtronic, Pfizer all have helped with creating more awareness on this topic. It was created in September 2011, and it raises awareness about PFDs and educates about treatment options and treatment plans. And these are some of the resources that are available on the internet, Facebook, Twitter, etc. So back to the pop quiz. As a woman, your chance of getting a pelvic floor disorder is 1 in. I guess it's not going. You should be highlighting. It's 1 in 3. Bladder control problems only occur in women after menopause. Obviously not true. The number of adults with bowel incontinence is 18 million, and then the risks of pelvic organ prolapse include all of the above.
Well, I just want to thank everybody. Our time is up, and I thank you for yours. I particularly want to thank our patient who's so courageous, who spoke up today. And thanks, Frogs, for sponsoring. Have a wonderful Thanksgiving with your family, and we hope to see you on voicesforpfd.org. Take care.